My presentation is on elderly living alone, the environmental and cultural factors. So to refresh a little bit from my previous presentation about health concerns, so nationally, ages 65 or older, 25.9% of elderly people live alone. Some of the social detriments of health that play a part in this are transportation, the housing design, physical barriers, availability of resources. And then for psychosocial, depression and loneliness, they're a higher fall risk and they're more prone to injury from their falls. Neglect can also be a part of elderly living alone, and then dementia-related problems can also be considered a health concern. So for how the media portrays elderly, often it can be positive. They can think of them as happy, active, influential, and have wisdom, but it can also be negative. They can think of them as being vulnerable, frail, being lonely, and dependent. And to be honest, they are accurate and inaccurate. It honestly depends on the elderly person. Lots of them are lonely, but lots of them are also happy. So in a way, the media is about 50-50. But they are at a greater risk for being misunderstood related to their vulnerability and dependent, because often the elderly living alone are obviously very independent. So for family support, this kind of depends on if it's positive or negative, on the duration, and the intensity varies. Some people are involved the whole time. Some people have to move back when their family member gets worse. They can help manage finances. They can provide emotional and social support, health and medical care. They can provide advocacy, surrogacy, end-of-life care, and care trajectories. And that is like a path or progression of development. And we'll actually go over that on the next slide of kind of how family can provide support, the benefits of them providing support. If no family support is available, they have a very poor quality of life, very lonely, very little access to good health care. So if you look at this is the care trajectory chart. So it talks about first they have to become aware. So then they can start taking them to physician appointments. They can help them run light errands. They can communicate with healthcare providers. They'll check in and monitor. So this would probably be more for my population of the elderly living alone. And then they start having the unfolding responsibility of doing household tasks. So they monitor symptoms and medications. They start helping with finances and household tasks. They'll hire care providers, like I mentioned in my last presentation. Usually it's private pay. They'll coordinate care and provide emotional support. And then they'll start to realize increasing care of demand. So personal care, they need to monitor their behavior and location. The personal care, deal with insurance issues, and provide acute care and manage symptoms. And then the end-of-life care, this is very advanced, minimizing suffering, symptom control. This would relate to hospice. So this is kind of a little chart to show how what family support can provide. And if you look at this, someone who's living alone who's missing out on all of these things mentioned down here on the sample tasks would have a very poor quality of life without family support. So the role that peers can play in elderly living alone, they can provide emotional support, transportation, they can help with finances. In addition, they promote better quality of life by just having a friend or someone to talk to, and it also provides the elderly with frequent checks, in case they were to fall in their home and nobody found them for days. But it can also be destructive, and one of the examples that I like to point out on this is caregiver burnout. They get burnout physically, physiologically, and sometimes it can lead to mistreatment. And then another thing that is destructive to elderly is they'll compare their health status to other people's health status. And so in a way, it can be destructive. So they can both be supportive and destructive. So for the culture environment of the cyclical nature, so it's more long-lasting than in the past. So more people are starting to live at home. They're actually seeing longer lifespans, and the baby boomers are coming up on being considered of elderly age. And then they do have a recurring vulnerability. They're a high falls risk, decline in function, depression, loneliness. This will always be recurring vulnerability in any elderly population in the different generations to come. So for the legal and political system, Medicare is provided for people ages 65 and older, and it can also be, right here, it mentions provided for people younger with disabilities, and that's often decided by Medicare what they'll cover if they have a disability. So it's federally funded. So on Medicare Part A, this includes hospital stays, skilled nursing facilities, hospice care, and home health. And then Medicare Part B, this provides doctor services, outpatient care, medical supplies, and preventative services. So this, the nice thing about Medicare, it's the same state per state, but it may not necessarily be covered by a doctor that you want to see in another state. You would still need to look up and see if that doctor is provided under the Medicare. And then the national coverage decisions, those are kind of determined on day-to-day basis by Medicare. So some of the potential barriers, the aging population is very diverse. The age ranges, from 65 all the way up to some people, I'm not sure the longest age that a person lives, but I know I take care of people at my work that are 102. Their ethnicity, language, education, and sexual identity. And in addition, as people age, they become more involved religiously and spiritually. Studies have been shown to prove that, and this can affect lifestyle and treatment options, and we'll go into that further on in the presentation. And then one thing, unlike international-wise, ageism, so negative attitudes about aging people. 60% in a World's Values survey reported that older people are not respected. 57 countries participated in this, so this is a large amount globally. And in fact, there's actually an International Day of Older Persons on October 1st. Okay, so socioeconomic status. So 10% of elderly live below poverty thresholds. 1 in 10 have a disability, which leads to them being unable to work. And then they rely on the Social Security disability insurance. But these benefits are anticipated to be cut at various times. And in addition, you need to remember too that people at age 65 are also going to start wanting to retire, or some may have already retired. Then elderly with a low socioeconomic status have a higher increased mortality rate. This is due to stroke, kidney disease, lower quality of life, and lower social relations. And in addition, risk factor for mental health. 15 million elderly will experience mental health problems by 2030. Okay, so a little bit about race and ethnicity. Our beliefs, behaviors, and values are shaped by our gender, age, race, and religion. So there's a lot that goes into making up as who we are as a person. So this is very difficult for health providers to provide competent care. For example, this is just one example, there's many. Language. Say if somebody comes into your clinic and they speak Mandarin Chinese, do you have an interpreter available? And in addition, healthcare staff equipped with the knowledge, religion plays a big part into how we receive our care. And a fact that I found interesting, Africans, Americans, Asians, Latinos, and Muslims report receiving poor quality of care because of race or ethnicity. That is quite a few different cultures that feel that way. Religion-wise, this is where I talked about that we get more into religion, how it affects us. Daily life, diet-wise. So for example, some religions can't have anything to do with blood, so often with meat, because of the animal's blood in the meat. And also, being vegetarian means that you can't have any meat. So this is a big area for people's protein. And next is fasting. Some religions fast once a month, holidays. It can range from, 1 meal to sometimes a couple days. And then this can also affect our treatment options. Certain religions refuse blood transfusions, sterilization procedures, and medications. Gender-wise, there isn't a ton on gender identification with the elderly. It more went into physical health problems. So for males, hypogonadism, erectile dysfunction, enlargement of the prostate, and for females, postmenopausal disturbances, urinary incontinence, breast problems, lung cancer, and then for both, a main one was malnutrition, falls, and cognitive dysfunction. So for Geographically, there is also some health disparities. Do they live in a rural or an urban area? Extreme weather, do they live in a place where hurricanes are common? Geographic distance, how far are they to the nearest doctor? Public transportation, do they have a bus route in their neighborhood? Are there challenging roads? Internet-wise, lots of elderly people don't know how to use the internet, and this plays into telehealth and telemedicine. If they know how to use the internet, it can have great positive outcomes, but it's also a negative outcome for them because many don't know how to use the internet. And if this becomes a normal norm, it's going to be really difficult for them to be able to have doctor's appointments. So, bias-wise, some implicit ways that people are biased are race, gender, unconsciously avoiding elderly, and unconsciously avoiding nursing homes. Some explicit bias areas are more like the comments. I hear often, hearing loss, that elderly can't hear, elderly are just confused, elderly can't smell, or elderly smell weird, or elderly drive slow. I hear that actually often with my family when driving, or that elderly don't know how to drive. So for an international scope, some areas that could have less health disparities, this is situational. It honestly just depends on where the person lives. For example, are they in a higher income area? If they are, they most likely probably have, good retirement and access to healthcare. Like I mentioned about if someone came into the clinic speaking Mandarin Chinese, are they where their race is popular and ethnicity is common? So if he was in China, he would probably be able to receive adequate care because people would be able to understand him, and that's a common language there. Do they have access to healthcare depending on where they live? Health behaviors. Do they live in a city that's common for smoking and that there's not very many ways to avoid it? And then is family involved in the areas that they live in? Family plays a huge part, like we mentioned earlier on in the slides. If family can be involved, that could help eliminate a lot of those disparities. In my presentation, now we'll go ahead and look at the references.